Thank you, Dr. Bassi, for the kind introduction, and I'm very glad to be invited here to speak in this instruction course. So my talk is on ethambutol and hydroxychloroquine toxicity, so no financial interest, of course. So I'm going to start off with a case with a 70-year-old male Chinese patient who was diagnosed with extrapulmonary TB in the abdomen, and he was treated with rifampicin, isoniazid, and ethambutol back in 2019. So typical a medical history of a 70-year-old man with ischemic heart disease, obstructive sleep apnea. Fortunately, his renal functions are normal. His normal visual acuity is near normal. So 9 months after starting on TB treatment, he presents with painless blurring of vision in both eyes for 2 to 3 weeks. So the visual acuity in both eyes went down to 618 with decrease in color vision. And this is what his Humphrey visual field looked like. So you can see that there's almost a bitemporal field defect here. So the OCT RNFL is completely normal, and so was the MRI brain orbit with contrast. The blood tests were non-contributory. I'm not sure why we did a pattern ERG, but perhaps because we weren't sure. We were investigating him as a visual loss of unknown cause, and it was consistent with both eyes optic atrophy. Both has optic neuropathy. So in the absence of an alternative course, and also with him being on ethambutol, we decided just to observe him without, by stopping the ethambutol. So we're very glad that he has some subsequent spontaneous visual improvement in the next 6 months. And in the next 6 months, his vision went back to the pre-morbid level with full color vision, and also his visual field defect resolved as well. So ethambutol optic neuropathy, well, I'm sure in India you know better than I do that it is commonly used to treat TB. The incidence of ethambutol optic neuropathy is at 1 to 2%. So other than stopping ethambutol, there's no effective treatment and is only partially reversible. So early detection is very important. So the risk factors are dose-related, and the comorbidities which could increase your risk include low body weight, hypertension, renal failure, concomitant use of isoniazid, vitamin E, and B12 deficiency. And of course, older age group patients are also more at risk. I think we've previously prepared this in a handout anyway, but I'm not sure where that is available. So
no, it's been uploaded.
It's been uploaded. So all the details and the references are there. So the is of insidious onset. It can happen anytime from 1 month to 36 months, with a median of about 8 months. So our patient, 9 months is just about the right time. So, and over 60% with painless, bilateral, symmetrical visual loss. They have dyschromatopsia and also visual field defect. And the bitemporal hemianopia is actually quite characteristic in ethambutol optic neuropathy. So there's no standard monitoring protocols and guidelines. If I ever have a chance to learn more about this from you guys, I would like to know what you guys do in India as well. So for us in Hong Kong, the basic eye exam, we have as a minimum, we have a visual acuity and color vision. And this is actually, in Hong Kong, is not done by ophthalmologists. It's done by the chest clinic who prescribe the TB treatment. And then the patients are instructed to self-observe for visual symptoms. And also in Hong Kong, because TB treatment is directly observed therapy, so they have to go every day for the treatment anyway. So in fact, they are in touch with healthcare professional on a daily basis. So if they have any problems, then they can actually tell, they can seek help quite easily. So if there are visual symptoms, then the ethambutol must be stopped. And in cases where they have delayed or slow persistent visual loss, then isoniazid may also be stopped. Okay, for high-risk patients, they require closer monitoring. So moving on to a second case, a 62-year-old female Chinese patient with a systemic lupus erythematosus on prednisolone, mycophenolate, and also hydroxychloroquine, initially on 400 milligrams daily. So as with a lot of Chinese ladies, they are quite light, so she's only 50 kilograms. So that actually works out to quite a high dose of hydroxychloroquine per kilogram per day. So she has normal renal functions, and she had been monitored at our hospital for over 10 years. So initially, she had normal visual acuity. With time, she actually developed some vague loss of vision, blurring of vision in the left eye, with slight drop of vision from 7.5 to 610, and also a paracentral scotoma. And at this time, the spectral domain OCT, so in the left eye, there's clearly an area of thinning which was not previously present. Although I have to say, if we had looked at the OCT more carefully back in 2023, we should have spotted that it was abnormal at that time. So the line across the macula is actually the best way to show it the structural damage. As you can see, the central is preserved, but the ellipsoid zone is completely destroyed outside the central macular region. So, and this was also confirmed with multifocal ERG, but to be honest, if the abnormality is so obvious on spectral domain OCT, you don't really need to do the multifocal ERG. So, in fact, if you look carefully at the other eye, even the fellow eye is abnormal. So, and this is the abnormal area, and this is what we need to pay special attention to the ellipsoid zone when we're monitoring patients for hydroxychloroquine toxicity. So the diagnosis is hydroxychloroquine maculopathy, left eye greater than the right. And of course, the management is stopping the hydroxychloroquine. So once again, there's no proven treatment for hydroxychloroquine or chloroquine maculopathy. So prompt detection is crucial so that we can stop it before further irreversible visual loss develops. As you know, with hydroxychloroquine toxicity, the risk rises with the cumulative dose. So that's not only the dose per kilogram per day, but also the number of years that the patient has been on hydroxychloroquine. So the risk factors are for hydroxychloroquine greater than 5 milligrams per kilogram per day, the duration of use greater than 5 years, renal disease, concomitant use of tamoxifen, and also if the patient has macular disease, it may affect the screening and susceptibility to hydroxychloroquine and chloroquine. So basically, for this, there are standard guidelines, the AAO guidelines, and also the Royal College of Ophthalmologists guidelines. So these are already included in the handout, but I'll just go through them briefly. So this is the AIOS2025. So they recommend using automated visual field and spectral domain OCT. Also, we can use multifocal ERG or fundus autofluorescence, but time domain OCT, full field ERG, EMSLA, color vision, and EOG are not recommended. So when to screen? So fundus exam within the first year of use, and then additional screening after 5 years of use, unless you have major risk factors. So for the Royal College of Ophthalmology guidelines, I'll just take 1 minute to go through this. So I think it's easier to follow, actually. So if you have no risk factors, screening begins after 5 years. If you have risk factors like the ones I mentioned just now, you should start monitoring after 1 year of drug therapy. So you should, I think Royal College has decided to use spectral domain OCT and wide field FAF is because visual field can sometimes be it requires a lot of patient cooperation. So sometimes if the patients are not cooperative, you get some false positive and you don't know what to do about it. So if it's normal, you just continue monitoring them annually. If both of them are abnormal, then it's definite toxicity and you should stop the medication. If only one of them is abnormal, you proceed to Humphrey visual field, and then you can also do the multifocal ERG. And if the multifocal ERG is normal, then you continue annual monitoring. If it is abnormal, then you go on, you stop the hydroxychloroquine. And similarly, if the visual field is abnormal, and the spectral domain OCT and the FAF are abnormal, then you go on to stop the drug. So in summary, there's no effective treatment. So the main teaching point is that to stop it promptly. So for Ethambutol, although there's no standard screening protocol, as a baseline, we need to do visual acuity and color vision at baseline and then self-monitor. And for hydroxychloroquine, we can either follow the AAO guidelines or the RCOP guidelines with funded exam at baseline and then annual screening after 5 years. For RCO, you screen with spectral domain OCT and FAF, which are quick. And if there are doubts, move on to Humphrey visual field. And if you're still not sure, use multifocal ERG. So thank you all for your for attention.
Thank you, Dr. Chan. Any questions? The question is, why not use the GCC, ganglion cell complex thickness, as a baseline for ethambutol toxicity?
Yeah, I think that's a really quite good suggestion, because as we know, if we just do the RNFL, because we may not be able to detect it very promptly, because even at the onset of visual symptoms, the RNFL is likely to be normal, whereas the GC-IPL may be reduced. However, I think as a screening test, I think as a national screening test, I think we, of course, involve healthcare policies, and if everyone needs to have a baseline, because even the visual acuity and the color vision is currently done by our chest physicians. So if all of them need to come in for an OCT, I think we need to consider how we can implement that. But I think that's a great suggestion.
I think RNFL is for the masses, and it's faster protocol, easily done. And also I think initially the RNFL thickness will increase before the GCC, it's associated with some amount of edema, RNFL thickening, even in ethambutol toxicity. Not in every case, but probably subtle increase in RNFL thickness might set in before. GCC is all about vision loss. It takes a little time, unless it's an ischemic optic neuropathy.
But the optic nerves can look entirely normal as well, and the RNFL
it
may
can have a
be
very
normal,
variable presentation.
so it can be quite variable.
I just have one quick question, Carmen. What is the timeline you decide that after stopping ethambutol, now this is time to stop INH?
This is actually a good question. I'd like to hear what you think as well. I think, for me, because any visual loss is irreversible, so I think maybe I'll wait for a month or so. If nothing has happened as yet, I'll ask them to stop the isoniazid. Well, consider alternative therapy to isoniazid, because after all, we have to take our chances. If we don't stop the isoniazid, if they do not have visual improvement afterwards, they may blame us for not stopping the isoniazid.
So maybe somewhere 4 to 6 weeks is what I think we plan in our country.
All right, okay. So it's great that, in fact...
And do you image all ethambutol suspected? Because you're going to have a bitemporal field loss. Do you image?
Well, anyone with a bitemporal field loss must image, because one man can have two diseases, and with bitemporal field loss, we can't afford to miss any pituitary or chiasmal pathology. Yeah, good point. Thank you.
Thank you. Excellent points. Any other questions? Any comments, Dr. Satya? Yeah, logically, if the INH should be stopped, if the vision.
I think definitely progressive loss, then the isoniazid should be stopped even sooner than 4 to 6 weeks. But if we stop the drug and if the visual loss is persistent and nothing has happened, I think 4 to 6 weeks is a great time to stop the isoniazid as well, even though it doesn't deteriorate any further. I think that's a great point.
Excellent points and an excellent talk.